Welcome to the Modern AT. In this presentation, we are going to break down evidence-based practice in athletic training. Evidence-based practice is often shortened to EBP, and it is one of the most important habits in modern healthcare. It is not just about reading research articles. It is about using the best available evidence, combining it with clinical expertise, and matching that decision to the patient's goals and circumstances. For students in athletic training, kinesiology, exercise science, physical therapy, anatomy, and sports medicine, EBP is the bridge between classroom knowledge and patient care. By the end of this lesson, you should be able to explain the EBP model, use the 5-step process, and apply it to a realistic athletic training case. The goal of this presentation is to make evidence-based practice feel practical, not intimidating. First, you should be able to define EBP. Second, you should understand the 3 major sources that guide the decision: research evidence, clinical expertise, and patient values. Third, you should be able to follow the 5-step process: ask, acquire, appraise, apply, and assess. Fourth, you should understand that not all evidence is equal, so study design and bias matter. Finally, you should be able to apply these ideas to athletic training decisions, such as injury evaluation, rehabilitation, return to sport progression, patient education, and outcome tracking. Evidence-based practice is the integration of the best available research evidence, clinical expertise, and patient values. That definition matters because it prevents 2 common mistakes. The first mistake is thinking that EBP means research alone. It does not. A study can tell us what has worked in a group of patients, but the clinician still has to decide how well that evidence fits the patient in front of them. The second mistake is ignoring evidence and relying only on habit or tradition. In athletic training, EBP helps us make clearer decisions about prevention, evaluation, rehabilitation, return to sport, and referral. It gives our care a stronger foundation and makes our reasoning more transparent. This triad is the core model of EBP. Research evidence helps us understand what has been studied and what is likely to work. Clinical expertise helps us interpret that evidence, perform skilled examination and treatment, and adapt care to the setting. Patient values remind us that care is not done to a diagnosis. Care is done with a person. An athlete's goals, preferences, resources, sport demands, and risk tolerance all matter. For example, 2 athletes may have the same ankle sprain, but one may need to return to recreational running, while another is trying to return to a playoff game. Evidence informs both plans, but the final decision must be individualized. A useful way to remember EBP is through the 5-step process. First, ask a focused clinical question. Second, acquire the best available evidence from credible sources. Third, appraise the evidence by judging its quality, relevance, and potential bias. Fourth, apply the evidence by blending it with clinical expertise and patient values. Fifth, assess the outcomes to see whether the plan is working. This is important because EBP is not a one-time action. It is a cycle. A clinician asks, searches, evaluates, applies, measures, and then adjusts based on the patient's response. The first step is to ask a focused question. PICO is one of the easiest ways to do that. P stands for patient or problem. I stands for intervention. C stands for comparison. O stands for outcome. Instead of asking a vague question like, "What should I do for an ankle sprain?" PICO helps turn the problem into a searchable question. In athletes with lateral ankle sprain, does balance training improve return to activity compared with standard rehabilitation? This version gives you search terms and helps you decide whether the evidence you find is actually relevant. A good question makes every later step easier. Once you have a clinical question, the next step is to acquire evidence. Searching is a skill. Start with the key PICO terms and then think of synonyms. For an ankle sprain question, you might search ankle sprain, lateral ankle sprain, balance training, proprioceptive training, rehabilitation, return to sport, and recurrence. Credible sources may include PubMed, Cinol, Sport Discus, Pedro, Cochrane reviews, and clinical practice guidelines. The goal is not to collect as many articles as possible. The goal is to find the most relevant and trustworthy evidence for the decision you need to make. Appraisal means deciding whether the evidence deserves your confidence. The evidence hierarchy is one way to think about this. Systematic reviews and meta-analyses often sit near the top because they synthesize multiple studies. Randomized controlled trials are often strong for intervention questions. Cohort studies, case control studies, case series, and expert opinion may still be useful, but they usually offer different levels of certainty. However, the pyramid should not be used mechanically. A poorly conducted systematic review may be less useful than a high-quality randomized trial. A study can also be well-designed but not relevant to your patient. Appraisal always includes quality, relevance, and applicability. Applying evidence is where EBP becomes patient care. A research article might support a particular rehabilitation strategy, but the athletic trainer has to decide how to use it with the patient in front of them. That decision should consider exam findings, injury severity, sport demands, timeline, access to equipment, adherence, and risk tolerance. This is where communication is essential. The patient should understand what the plan is, why it was chosen, what signs of progress are expected, and when the plan might change. Evidence does not remove clinical responsibility. It gives the clinician a stronger foundation for making and explaining decisions. The assess step is often where clinicians become better over time. It asks whether the patient is improving in ways that actually matter. In athletic training, that can include patient-reported outcomes, such as pain, function, confidence, and sport readiness. It also includes objective measures, such as range of motion, strength, balance, hop performance, swelling, workload tolerance, and sport-specific tasks. Outcome assessment helps prevent two errors: keeping a plan that is not working, or progressing an athlete without enough supporting data. Good EBP is iterative. You apply a plan, measure response, then decide whether to continue, progress, modify, or refer. This case demonstrates how EBP works in a realistic athletic training scenario. A basketball athlete sustains an acute lateral ankle sprain. The athletic trainer begins with evaluation and clinical impression. Then, the plan integrates three sources: current research evidence, the clinician's experience, and the patient's goals. The rehabilitation progression moves from acute management to early motion, strengthening, balance, advanced training, and return to sport decision-making. Notice that outcomes are tracked throughout the process. The clinician does not simply say the athlete looks better. They use pain, function, strength, balance, sport-specific testing, and clinical checkpoints to decide whether the athlete is ready to progress. Evidence-based practice is not limited to choosing rehabilitation exercises. It appears across nearly every part of athletic training. In injury prevention, evidence can guide warm-up programs, heat safety policies, bracing decisions, workload conversations, and hydration strategies. In evaluation, evidence helps us understand which tests are useful and when referral is appropriate. In intervention, evidence informs exercise selection, manual therapy decisions, progression, and return to sport criteria. EBP also improves communication because it helps clinicians explain why a plan was chosen. Finally, EBP supports outcomes assessment and professional practice by encouraging documentation, protocol review, and continuous improvement. There are real barriers to evidence-based practice. Time is a major challenge, especially in busy athletic training settings. Access to journals can also be difficult outside of university systems. Confidence matters too. Many students are still developing skills in statistics, study design, and critical appraisal. Finally, even strong evidence can be hard to translate into a unique patient situation. The solution is not to become perfect overnight. Start small. Choose one clinical question from your week. Find one credible article or guideline. Identify the main finding, the main limitation, and whether it applies to your patient. Then choose one outcome to track. That habit builds EBP skill over time. Here are the major takeaways. Evidence-based practice is integrated. It combines research evidence, clinical expertise, and patient values. Good questions matter because a focused question helps you search for useful evidence. Evidence quality matters because not all studies are equally trustworthy or equally applicable. Application must be individualized because the patient's goals, sport, resources, and circumstances influence the care plan. Finally, outcomes close the loop. EBP is strongest when clinicians measure progress and adjust based on response. For athletic trainers, this process supports safer and more defensible decisions across prevention, evaluation, rehabilitation, and return to sport care. These selected references provide a foundation for understanding evidence-based practice and applying it in athletic training and sports medicine. The classic BMJ article is frequently cited for the basic definition of evidence-based medicine. Users' Guides to the Medical Literature is a major resource for learning how to evaluate and apply research. Athletic training-specific evidence-based practice resources help connect those broad healthcare concepts to sports medicine decisions. As always, evidence evolves. A strong clinician keeps learning, keeps asking better questions, and keeps evaluating whether patient care is achieving meaningful outcomes.